You can project your slide. And today's session is on falls and approach to falls. So exam going student can participate more. Dr. Ratnesh is presenting his slides and discussion. If anybody wants to actively participate, they can. So Dr. Ramkrishna, can you start recording?
Take minutes, sir.
So today's moderator is Dr. Noel Gomes. Welcome him. Uh, yeah, Dr. Ratnesh Sharma, you can start. And Dr. Noel Gomes, you can introduce yourself. And then Dr. Ratnesh, then we'll start.
Yes, good evening. I'm Dr. Noel Gomes. I'm a neurologist from Topiwala National Medical College and Nair Hospital. Ratnesh, you can start the presentation.
Yeah, Dr. Ratnesh, go ahead.
Tema.
Ratnesh, we are not able to hear you.
Ratnesh, you are not audible.
Hello. Hello.
Yeah,
Hello.
go ahead.
Yes, sir.
Yeah, you're audible.
Yes, sir. Sir, I would like to start with the gait and its anatomical aspects. Gait refers to the coordinated cyclical pattern of limb movements that enable bipedal locomotion in humans. The major anatomical structures responsible for equilibrium and locomotion are brainstem locomotor regions, that is the subthalamic and the subthalamic nucleus and midbrain, cerebellar locomotor regions. Above both project to the pontomedullary reticular formation, which further projects to ventromedial spinal cord and spinal interneurons via the reticulospinal tract. Sir, the major regions are brainstem locomotor regions and cerebellar locomotor regions. They provide input to pontomedullary reticular formation, which provides the input to the central pattern generators, that is the spinal interneurons. So these then provide further input to the limb and trunk muscles. The stimulation of the brainstem locomotor regions leads to increase in axial and limb muscle tone, thereby adoption and maintenance of upright posture before the stepping begins. And the spinal interneurons drive the motor neurons of the limb and trunk in a patterned and repetitive manner so as to produce stepping movements. So additional sensory input is given to this system via a proprioceptive system, sensory system, auditory system, and visual system. And further input, higher cortical input is given onto these centers via frontal lobe and its connections, especially via basal ganglia, and via cerebellum, that is the floccular nodular lobe and anterior lobe and its connections. The frontal lobe modulates postural responses and enables the precision foot movements. And dysfunction of frontal lobe is the cause for higher level gait disorders. And the cerebellum modulates the rate, rhythm, force, and amplitude of stepping movements and maintains posture and equilibrium. Sir, shall I proceed?
Uh, it is brainstem locomotor. So the spinal interneurons actually, these are called as CPGs or central pattern generators.
Yes, sir.
So there is rhythmic burst of reciprocal activity in both flexors and extensors. So that
Yes.
actually produces the step movements. That is when we take the steps. while the brainstem locomotor region is mainly responsible for maintaining the erect posture while walking.
Yes, sir.
Okay, yeah. And how does the parietal cortex help?
Sir, providing input, parietal cortex provides the motor programs and the planning of movements, and it also integrates
Okay, so
the
parietal mainly it helps in sensory input. So it is
Yes, sir.
joint position, orientation of the body, and
Yes,
the speed and direction also is given by the parietal lobe, and also the motor cortex is just adjacent to the parietal lobe.
yes,
So this input is given to the output also.
yes, sir.
Okay, you can go ahead.
So moving on to the gait cycle and locomotion. Locomotion involves the propulsion of body-wise sequential stepping movements to the lower extremities in a repetitive gait cycle. The gait cycle is defined as the sequence of movements from heel strike to the next heel strike of the same foot. The gait cycle consists of mainly two phases, the stance phase or support phase and swing phase. During the stance phase, the given foot is in contact with the ground. The heel strikes the ground first, followed by the sole of the foot and then the toes. And the other foot will be in the swing phase at the time. As soon as the weight is transferred to the supporting leg, the opposite leg begins its movement, which is referred to as swing phase. During the swing phase, the foot must be maintained in dorsiflexion. And from the moment one heel returns to the ground and the other, until the other foot leaves the ground, the body is supported briefly by both feet. This is known as the double support phase.
Just go ahead.
Yes. Sir, I'll go through the phases of normal gait cycle. The first phase is the initial contact or the heel strike. This occurs when the heel of the foot contacts the ground, followed by loading response, that is the initial double limb support. This occurs after initial contact of the right foot to the ground until the left foot is taken off the ground. During this loading response, body weight is transferred onto the support limb, that is from left to right or from right to left. In the mid stance phase, from elevation of the left leg until both ankles are aligned in the coronal plane. In this, only one limb carries the weight. In the terminal stance, this begins when the heel of the right leg starts to rise from the ground and continues until the heel of the left leg touches the ground. This is followed by the pre-swing phase of the other limb. That is the second double limb support from the initial contact of the left heel to the ground just before the elevation of the right leg off the ground. Followed by swing phase. The initial swing phase, that is the toe off, is the elevation of the right leg to the point of maximal knee flexion, followed by mid swing phase, that is the foot clearance. This follows the knee flexion to the point where tibia is almost vertical. And after this, there is a terminal swing phase. This is from the point where the tibia is vertical to just before the initial contact, that is heel strike of the right leg, hence completing one full gait cycle.
Okay. Do you know what is a normal distance between when the patient stands, that is in stance phase, when both the feet are together on the ground? Normal, what is the stance?
The normal stance is, sir, around 1.3 to 1.5 meters, so the normal stride length, and the
No,
distance
a
between the two
stance.
malleoli.
When a patient is standing, what is a
Yes,
normal a stance? We say normal stance, wide stance.
sir, more than 15 centimeters is considered to be wide stance, and the normal is between 10 to 15 centimeters.
Yeah. Okay. And normal step length.
So normal step length is somewhere around
So what
65
is a
to,
step?
sir, step is half of the stride length, that is from the heel
So it
strike
is
phase to the,
one. Yes. So it is between one leg and the other leg.
yes, sir.
So that is how much. Usually it is around 2.5 feet or 30 inches.
Yes, sir.
And stride.
So stride is somewhere around 1.3 to 1.5 meters, sir.
Okay.
Yes.
To 5 feet. Normal.
Yes, sir.
Okay, go ahead.
So this is a graphical representation of step sequence in classical gait disorders. First one is normal. Second one is spastic paraparetic gait. The feet are kept, the Base is narrow. The feet are kept close together while walking. The stride is decreased. The step length is decreased. And C is cerebellar ataxic gait. That is, the rhythm and coordination of the gait has been disturbed. The step length, the stride, and the base varies and the stride length varies. D is Parkinsonian gait, where there is a short shuffling gait, while E is frontal or magnetic gait, in which there is a narrow step width and irregular walking. So moving on to commonly used terms in gait cycle. First is cadence, that is the number of steps in unit time or the rapidity of stepping. Normal is around 90 to 120 per minute. Followed by stride length, that is the distance covered during one full gait cycle. Normally is around 1.3 to 1.5 meters. This is shortened in hypokinetic movement disorders and pyramidal tract dysfunction, especially MND, and rarely it is increased in vestibular dysfunction or cerebellar ataxia. Step width is the side-to-side distance between the feet, between each medial malleoli. Sir, wanted to confirm regarding the step width. Some places it is given 5 to 10 cm, some places more than 15 abnormal is given. Sir, what should we quote as the
Actually, it is
normal?
not given in books. It is given in multiple books. So I think 5 to 10 is normal. Otherwise, you can say 5 to 12 also.
Yes, sir. Okay, sir. So followed by a step height, the maximum distance between the forefoot and the ground during the swing phase, that is 1 to 2 centimeters. The symmetry is comparison of step length and timing between the left and right legs. Normally it is symmetric. It may be asymmetric in unilateral cerebellar or sensory ataxia. And coordination is the timing of leg activation with respect to the other leg in gait cycle. Normally it is smooth and well coordinated. Variable step timing can be seen in basal ganglia disorders or due to sensory or cerebellar ataxia.
Yeah, you can go ahead.
Yes, sir. So moving on to equilibrium, there are two types of equilibrium, that is the static equilibrium and dynamic equilibrium. The static equilibrium is stability when standing. It relies on musculoskeletal linkage between the trunk and legs, postural reflexes, that is writing reaction and anticipatory movements, and sensory inputs from the visual, vestibular, and proprioceptive systems. So dynamic equilibrium is especially for turning movements, obstacle avoidance, and postural adjustments. I would like to start with approach to
So what are
history.
the writing reflexes?
Sir, on anticipation of a fall or on any obstacle which is observed during the
Okay,
gait cycle,
so the
the patient
writing
will.
reflexes actually they help in writing or correcting whatever abnormal postural changes occur, and it helps to maintain posture. Posture as in the head, the neck on
Yes,
the body, and the body. So there is labyrinthine writing reflex, which is mainly for the maintaining the position of the neck or position of the head. Then there is
yes,
neck writing reflex, which maintains the position of neck on the body.
yes, sir.
Then there is body writing reflex and visual writing reflex. And there are two other, those are anticipatory and the postural or protective postural response.
Yes, sir.
So the anticipatory is one where during the change in position or during the change of posture, for example, when the person is trying to stand up from sitting position, here the anticipatory writing reflex helps to prevent fall or to prevent the disequilibrium.
Yes, sir.
Okay, okay, you can go ahead.
Yes, sir. Sir, first of all, we should ask the patient or the relatives whether there is any abnormality or change in gait. Is the patient walking slower, taking more steps, having difficulty turning, having difficulty going up steps, or is the patient veering towards any one side? Is there any history of falls? In falls, we have to ask for the circumstances of falls, the frequency of fall, any prodromal symptoms such as giddiness, diminution of vision, sensation of cold extremities, or anything favoring orthostatic hypotension. We should ask for history of loss of consciousness, the duration, any history of seizure disorder, startle sensitivity, excessive daytime sleepiness, if the falls are precipitated by strong emotions, history of any headache or migraine attacks with weakness, history of any vascular risk factors, history for sensory and motor examination, that is sensory loss, paresthesias, any limb weakness or stiffness, any joint pain, swelling, or any contracture. Is there any visual impairment or hearing loss or tinnitus or vertigo? Is there any history of cognitive impairment or abnormal involuntary movements or any drug, alcohol, or toxin exposure?
Okay, are you going to discuss this?
Yes,
Little
sir.
bit?
Further, I have discussed all of
Yeah, yeah,
the.
okay.
Sir,
Yeah, so what is fall?
sir, falls are any sir, loss of posture which is not corrected by the corrective mechanisms, resulting
So it is
in.
basically inability to maintain upright during any postural challenge. This is what is given in Bradley.
Yes, sir.
And what is drop attack?
So drop attack is falls without any loss of consciousness, and in drop attacks usually there is a transient hypotonia, mainly of the lower
So it
limbs.
is actually sudden fall occurring without a prodrome,
Yes, sir.
which may or may not be associated with loss of consciousness. And it cannot be prevented by assistive devices. That's what is given in Bradley.
Yes, sir.
So that's how the falls are basically divided. So there is something called as toppling falls, and this toppling falls is an umbrella term where the muscle tone is retained. And when it is not retained, the patient. So what are the causes or that those are called as collapsing falls basically.
Yes, sir.
So can you give few examples of drop attacks?
Sir, for examples of drop attacks are mainly, sir, syncope. It can be due to a cardiac syncope. It can be due to orthostatic hypotension. Drop attacks can be due to seizures, that is Lennox-Gastaut syndrome and Dravet syndrome. And drop attacks can also occur in transient ischemic attacks and sir, abnormalities of third ventricle and posterior fossa, such as colloid cysts, Chiari malformations, and
Yes,
it
so
rarely can occur in.
one is syncope due to any cause.
Yes,
Then seizures. So that is basically atonic seizures. It could be transient ischemic attack because of vertebrobasilar insufficiency, or sometimes anterior cerebral artery also because it supplies the lower limbs.
yes, sir.
Then third ventricular cyst or tumors. So that can cause acute occlusion, acute hydrocephalus, and then they can have drop attack. Then
Yes,
Chiari malformations, cataplexy, which is a part of narcolepsy also.
yes, sir.
And there is acute otolithic crisis, which is also called as Tumakin crisis.
Yes, sir.
That can also cause sudden severe vertigo, and they can be drop attack.
Yes, sir.
Yeah, okay, go ahead.
We should also ask whether the patient has any subtle deficits, such as difficulty putting on undergarments or trousers, requiring balancing on one leg. We should also ask for modifying or exacerbating factors. That is the walking more difficult in dark? Is the walking more difficult when being distracted by extraneous stimuli? Is the walking more difficult in crowded places and in patterned or glazed floors? Does the gait improve with suggestions or trivial support? And we should also ask if there is any other neurological deficit or any possible etiological factors which might be cause for the drop attacks or falls. So first, the first symptom in history I would like to cover is weakness. Many patients attribute any gait or balance problem to leg weakness, even though none is detected on examination. However, weakness of certain muscle groups produces characteristic difficulties during particular movements of gait cycle. For example, patient may complain of catching or scraping a toe on the ground and a tendency to trip, which favors foot drop or spastic equinovarus found in paraplegia and hemiplegia. There can be buckling of knees with sensation that legs will give way when standing or walking downstairs. This is due to weakness of the knee extensors. Shallow stepped or high stepped gait is due to weakness of ankle plantar flexion. A difficulty climbing stairs or rising from a seated position can be due to proximal muscle weakness, that is hip extensors and knee extensors. And difficulty turning in bed or difficulty turning in general and difficulty raising head from pillow can be due to axial muscle weakness. Moving on to history of slowness or stiffness. History clues which favor hypokinetic movement disorders are slowness of gait, shuffling gait with short, shallow steps, difficulty initiating stepping when starting to walk, that is start hesitation, or when an obstacle is encountered, the patient has difficulty walking or turning, this is freezing. This is common in advanced stages of Parkinsonism. History clues which favor spastic paraparesis or hemiparesis are complaints of stiffness or heaviness or legs that do not do what they are told. History of dragging legs, catching of the toes of their shoes or surface irregularity. Leg may suddenly give way, causing stumbling and falls. In some patients, muscle tone may be normal when supine and leg stiffness may only occur while walking. And sometimes the stiffness can be brought out by asking the patient to walk faster. Similarly, dystonia in children and exercise-induced foot dystonia in adults may be evident only on walking or running. A difficulty rising from a chair or turning in bed and general decline in agility may be due to loss of truncal mobility in diffuse cerebral vascular disease, hydrocephalus, and basal ganglia diseases.
So in slowness, whatever slowness history which you have told, that is mainly for lower limb slowness, or you
Yes,
can say lower limb Parkinson's. So you need to ask history for upper limb Parkinson's also. So
yes,
basically, IPD or idiopathic Parkinson's usually starts from upper limb and then is lower limb. So patients will have history of slowness of his daily activities. So the relatives may say there is slowing while doing his daily works like brushing their teeth, while eating food, while writing, while doing some fine activity,
yes,
uh, while screwing, unscrewing. So all these activities you have to ask what are the daily activities and whether the relatives have noticed any slowing.
yes.
Yes, go ahead.
So moving on to history of imbalance, patient may have complaints of poor balance and unsteadiness. This is a cardinal feature of cerebellar and sensory ataxia, but it may also occur in other neurological disorders and are particularly common in the elderly. History clues which favor cerebellar ataxia are unsteadiness, staggering, inability to walk in a straight line, and near falls. Turning and suddenly changing directions results in veering to one side or staggering as if intoxicated, and it can be exacerbated by an uneven support surface. History clues favoring sensory ataxia, unsteadiness when walking in the dark, complaints of being uncertain of the exact position their feet are walking of their feet when walking. Patient may also complain of numbness, paresthesias, cotton wool sensations, or inability to appreciate the texture of ground beneath. History clues which favor vestibular ataxia are veering and a sense of imbalance while walking in environments with many moving objects, for example, shopping mall or a crowded street. And history favoring higher level gait disorder, that is subcortical cerebral vascular disease or basal ganglia disorders, are imbalance which manifests while turning, when turning while walking, while stepping backward, or bending over to pick up something, or performing several tasks simultaneously, such as walking and carrying an object, or walking and talking to someone else.
In this cerebellar ataxia, usually they give history of difficulty in walking on narrow lanes.
Yes, sir.
So how will you ask that history?
So we can ask the patient in a tightly closed or a narrow passage. While, for example, going through doors or going through narrow passageways, does the patient have increased difficulty, and whether the difficulty improves on a open area, wide open area?
Okay, that is one. One is the small corridors in buildings or
Yes,
in halls. That is one. Second is sometimes they walk on narrow bridges or the railway tracks, so they can have difficulty while walking on that also. So this history you can ask.
yes, sir.
Okay, move on.
So moving on to falls and its types. Falls are mainly of 7 types. The first is collapsing falls, that is drop attacks. This is due to sudden loss in muscle tone. Toppling falls. These are falls with retained muscle tone. This can occur as drifting and falling while standing, or falling while changing posture or position, or it can occur due to weaving from side to side and then falling. Other types of falls are tripping, freezing, falls due to vestibular dysfunction, sensory falls due to impaired sensory function, and non-patterned falls.
Yeah.
Sir? Yes, sir. So moving on to collapsing falls, that is drop attacks, described as collapsing in a heap, the patient relatives say he has collapsed all of a sudden as if the body has collapsed into a heap of bones. It results from loss of postural tone. It is sometimes referred to as drop attacks. Consciousness is mostly retained or fleetingly clouded. There is no post-fall confusion. Common causes are akinetic seizures, negative myoclonus, syncope, autolytic crisis, orthostatic hypotension, TIA, and third ventricular and posterior fossa abnormalities. So moving on to toppling falls. These are falls with retained muscle tone.
Yes, go ahead.
Yes, sir, the characteristics of toppling falls are the patient falls in some direction and does not just collapse. The patient topples as if like a falling tree. The patient drifts off balance with no apparent effort to correct balance. These falls may be due to inadequate postural control that is seen in PSP, that is backward falls, can be seen in MSA, in late stages of IPD, and in frontal gait disorder. This is due to disorganized synergistic contraction of muscles required for postural control, especially when rising from lying to sitting position and sitting to standing position. For example, when patient tries to get up from a sitting to standing position but does not bring the feet under the chair to keep the center of gravity beneath feet. Hence, the patient may fall either forward or backward. Or while standing, the patient may drift out of equilibrium state due to a distorted sense of body verticality. This is seen in thalamic astasia, putaminal astasia, and Pusher syndrome. The Pusher syndrome occurs in stroke patients, that is lateropulsing, where the patients actively push themselves to the weaker side, resulting in balance and gait impairments. Or it can also be due to problems with balance. Patient may weave in any direction while standing due to increased body sway, resulting in a fall. But unlike the previous situation, that is inadequate postural control, they retain the protective responses. I'll move on to
Go ahead.
Yes, I'll move on to other types of falls. Third type is tripping. This occurs due to when the feet do not clear the forefoot of the ground adequately. This is seen with foot drops, spasticity, or Parkinsonism. Freezing. Falls can occur during freezing because the feet get stuck to the floor when walking or during initiation of the gait while the center of mass continues to move forward. This can occur during fascination because the steps become progressively short with increasing speed and they are inadequate to keep the feet under the center, moving center of mass. These type of patients usually fall forward on their outstretched arms. And falls due to vestibular function, the patient tend to drift to the side of the labyrinthine lesion. This is more when the patient closes his eyes or in the dark or in sensory conflict situations, such as when the patient is walking on a moving platform, such as a treadmill or a escalator or stairs. These type of falls occur in both peripheral and central vestibular lesions. And other types of falls are the sensory falls. This is due to sensory ataxia, occurs more while walking on uneven surfaces. And these patients are generally aware of their balancing deficit and try to protect themselves using their arms to grab nearby objects or voluntarily sit down. And they tend to use sensory cues like visual input and walk with their eyes glued to the floor. Non-pattern falls are due to they do not fit into any consistent pattern. The abnormality represents failure of attention and insight, resulting in carelessness. This is usually seen in patients with dementia, frontotemporal dementia or subcortical dementia. So other points which should not be missed in history are history of urinary urgency and incontinence. This favors localization of spinal cord or parasagittal frontal lobe or subcortical dementia. Urinary symptoms can also be a part of non-motor symptoms of PD. Cognitive impairment history should not be missed. Cognitive impairment is associated with slowing of gait speed, executive dysfunction, inattention, impaired multitasking, and set switching may predict later development of falls in older adults without dementia or impaired mobility. Dementia with disinhibition and impulsivity is associated with the reckless gait patterns and falls, especially in FTD. We should also ask for history of drug use, such as any anti-epileptic use, any antihypertensive use, any drug which may affect the postural stability. We should ask for use of toxin or alcohol exposure, history of sleep for history of cataplexy, excessive daytime sleepiness, and for joint pain or any joint deformities. And yes, sir. We should also not miss out on motor, sensory, and skeletal examination. Sir, should I move forward to?
You're finished falls. You're finished falls.
Yes, sir.
Yeah, we finished. Okay, so in history, what will you ask? Like patient comes with history of falls.
Sir, first off, I'll ask the patient what circumstances did the fall occur in? Was
Yes,
it?
so you should know the whole story, that what was the full story, and suppose if there are 4 to 5 falls, you should tell about those falls in detail.
Yes,
So one thing is you need to know whether it was a provoked fall or unprovoked fall.
yes,
Okay, and whether it was associated with any prodrome, whether it was associated with vertigo, which is necessary to roll out vestibular falls, then whether it was associated with loss of syncope or presyncope. For exam cases, it is important in multisystem atrophy. Also, patients with Parkinsonism, advanced Parkinsonism can have significant orthostatic hypotension, whether there was associated presyncope, loss of consciousness, any involuntary movement, that is seizures, and secondly, if the patient had any injuries secondary to the fall.
yes,
So usually, patients, due to not drop attacks but falls because of neuromuscular or other causes, especially atypical Parkinsonism or Parkinsonism, if they're conscious, they will try to prevent injuries, major injuries. So even if they fall, they may not have major injuries. So that's to be asked. But in advanced
yes,
Parkinsonism, in advanced atypical Parkinsonism like PSP, they may fall like log of wood and they may sustain injuries.
yes, sir.
Okay, then it is important to know what were the other circumstances during fall. What was the patient doing? Whether he was walking, whether he was turning.
Okay, sir.
Okay, so that is exacerbation. Whether there was exacerbation in dark, that is for sensory ataxia. Whether it was during turning. So during turning can occur in hypokinetic movement disorders also, and it can occur in cerebellar disorders also.
Yes, sir.
Whether there was fall on due to uneven surface while walking on uneven surface, that is also important for in the cerebellar ataxia.
Yes, sir. Should I move
What
forward,
are
sir?
the examples of falls?
Yes, sir. Sir, examples of falls, as in, sir, the types of falls or
In neuro, it will get a in neuro.
yes, sir. Sir, your voice is cutting, sir. Cannot hear clearly.
What are the type of falls in neuromuscular disorders?
Sir, in neuromuscular disorders, the falls may be due to distal muscle weakness or can be due to proximal muscle weakness or
Yes,
can
so
be due to.
distal muscle weakness, it can be because of peripheral neuropathy,
Yes, sir.
uh, or distal myopathies like GNE myopathy. They have tripping falls.
Yes, sir.
So there is instability of the ankle because of weakness of the distal muscles. So that can cause tripping falls.
Yes,
So
sir.
usually they say कि that uh, there was twisting of ankle and the patient fell. It could be while walking or during running also.
Yes,
Then
sir.
if there muscle weakness there,
Yes, sir.
in proximal muscle weakness or other muscular dystrophies or limb girdle muscular dystrophies.
Sir, patient can have a fall while getting downstairs because
So
of
they
the
are
buckling.
buckling falls.
Yes, sir. Buckling
So
fall.
there is weakness of the quadriceps, and then it could be while running, it could be while climbing stairs. There can be buckling because of weakness of the quadriceps muscle.
Yes, sir.
What about cerebellar?
Sir, while turning, mainly cerebral ataxia patients have falls, and
Yes,
when they are asked
so
to.
you need to know whether there was any swaying, and
Yes, sir.
whether the relatives noticed any swaying while falling, uh, whether he was turning when he fell. Now,
Yes, sir.
okay, and whether uh, the fall was some surface.
Yes, sir.
This tripping falls can also be because of some obstacles. Suppose they are running or they are walking and there was a huge obstacle and they tried to overcome the obstacle, they can be fall because of that also.
Yes, sir.
Okay, then what about Parkinsonian disorder?
Sir, falls in Parkinsonism are mainly due to freezing of gait due to postural instability and due to fascination, sir.
Yes, so progressive supranuclear palsy, mainly the falls are posteriorly, that
Yes, sir.
is backward falls. That is because of, first of all, they have uh, downward gaze restriction.
Yes, sir.
So they try to look upwards and they have axial rigidity, so they tend to fall.
Yes.
The fall can be while getting up from bed also, they can fall backwards. Or
Yes.
getting up from chair also, they can fall backwards.
Yes, sir.
Uh, then in Parkinson, in IPD, what are the factors that contribute to falls?
Sir, mainly it is the freezing followed by postural instability, followed by, sir, cognitive impairment, mainly
Yes.
frontotemporal impairment, and rigidity and leg weakness can also result in falls in IPD, sir.
So, one is duration. So, the duration is also important
Yes, sir.
because if there is long-standing progressive Parkinsonism, they will have falls. So, that contributes. Second
Yes, sir.
is, again, cognitive impairment that contributes to fall in Parkinsonism. Then, treatment-related fluctuations.
Yes, sir.
Patients who have severe levodopa-induced dyskinesia, they can have falls because of the dyskinesias.
Yes, sir.
Then, patients who are receiving sedative drugs. So they can have falls because of those sedating drugs.
Yes, sir.
Then again, autonomic dysfunction. It could be cardiovascular, that is orthostatic hypotension or cardiac autonomic dysfunction. Also, they can have falls. And important is freezing of gait.
Yes, sir.
So this freezing while walking because pulling gait and then they are freezing. So this can also contribute to fall.
Yes, sir.
So this freezing of pathology of gait.
Sir, your voice is not clear, sir.
What is the physiology or pathophysiology behind freezing of gait?
Sir, mainly the center of mass during freezing, sir, the feet get stuck to the ground and the center of mass continues moving forward, resulting in a freezing. And as the center of mass moves forward, the patient has a fall towards front side. Mainly, sir,
So basically, the brainstem or
yes,
mesencephalic locomotor balance center that is responsible. So
yes,
pedunculopontine nucleus.
yes, sir,
So it is one of the key factors for postural control. So that so involvement of that is responsible for falls and freezing of gait in Parkinson's.
yes,
Basically, cholinergic striatal pathway it is called as.
yes, sir.
Yeah, I think we have covered most of the things. Falls. Okay, so how can you prevent falls?
So prevention of falls in Parkinsonism is via, sir, adequate drug dose
No,
adjustment.
in any falls, so neuromuscular falls.
Sir, if the patient has a distal muscle weakness, we can ask the patient to wear prosthesis for distal muscle weakness. That is
Yes,
the
so
ankle
orthosis
prosthesis,
or
orthosis.
yeah, or walkers, ankle foot orthosis for foot drops.
Yes,
So that then
sir. Other than that, we can ask the patient for using a walker or a stick, and physiotherapy and other strengthening exercises can also be advised.
yes, then high risk like climbing stairs, climbing ladder, darkness or low illumination. All this we have to avoid.
Yes, sir.
Then drugs which cause hypotension and which are sedating,
Yes,
those
yes,
we
sir.
have to avoid. Then flat shoes or shoes with low heel, that can be one. And in Parkinsonism also, sticks, patient's gait can improve with cue, especially freezing of gait can improve with cues.
Yes,
So currently there are canes available with laser marker and the patient can follow the laser, which helps the patient to
yes,
walk and to avoid freezing of gait.
yes,
Okay, you can move ahead.
yes. Sir, I would like to move forward with examination. Sir, is my screen visible clearly?
Yes.
Yes, sir. Sir, this is tested under 6 major subheadings. First is arising from stand to seated position, followed by standing, followed by walking, turning while walking. Other maneuvers and motor, sensory, and skeletal examination also should not be missed. So first is arising to stand from seated position. In this, we can assess the proximal muscle strength, organization of the truncal and limb movements, the stability of the stance and the stance base. In standing, we assess the posture, the stance base, body sway. Romberg's test is done and pull test is done. During assessment of walking, we assess the initiation of walking. Is there any freezing? Is there any initiation difficulty? We assess the speed of walking, the width of the stance base. We assess the step length, the cadence, rhythm, and tempo of stepping. We assess the step trajectory, whether it is shallow shuffling or high stepping. We assess the associated trunk and arm movements, and we also assess the trunk posture. Turning while walking, we assess the number of steps required to turn, the number of stabilizing steps if the patient has imbalance, en bloc movements, that is truncal or limb en bloc movements, and freezing. Other maneuvers to be tested are tandem walking, walking backwards, running, and walking on heels and toes. And we also should conduct motor sensory and skeletal examination. So moving on to first point, that is rising to stand from seated position. Herein we assess proximal muscle strength, organization of truncal and limb movement, stability and stance base. Here we have to ask the patient to rise from a chair without using the arms. And this informs us about the pelvic girdle strength, control of truncal movement, coordination, and balance. If the patient has inability to rise when feet are appropriately placed under the body without using arms, this may indicate a proximal muscle weakness. An abnormally wide stance base often signals incoordination or imbalance. And when the feet are not positioned directly under the body, then as a result, the trunk leans backward when a person is trying to stand. This is seen in frontal lobe disease and higher level gait disorders such as Parkinson, progressive supranuclear palsy, that is rocket sign. In Parkinson disease, the patient tends to fall forwards. In PSP, the patient tends to fall backwards. Moving on to standing, we assess the posture, stance base, body sway, Romberg's test, and pull test. The trunk is normally upright during standing and walking. The abnormalities of posture are as follows. Flexion of the trunk and stoop posture is characteristic of late Parkinsonism. Slight flexion at hips to lower the trunk is common in many unsteady or cautious gait syndromes in elderly. Upright posture with neck and trunk extension, that is the gunslinger gait, is typical of PSP. The forward flexion of neck can occur with weakness of the neck extensors in MND, myasthenia, and myopathies, but a dystonic manifestation of forward flexion of neck, that is the antecollis, is seen in MSA and Parkinson disease. Lateral trunk flexion or PISA syndrome is seen in PSP. Camptocornea is seen in Parkinson, that is the progressively worsening forward flexion of the trunk and the body, which worsens on walking and improves on lying supine. Exaggerated lumbar lordosis can be due to paraspinal muscle spasm, stiff person syndrome, or proximal myopathies. Lateropulsion can be due to acute vestibular imbalance, lateral medullary syndrome, and posterolateral thalamic lesion, that is a Pusher syndrome. So width of the stance base when rising from sitting, standing, walking, and turning gives us an indication of balance. The widening of stance base is an efficient method to decrease the body sway in the lateral and anteroposterior planes. The patients whose balance is insecure for any reason tend to adopt a wider stance. Intermallear distance is more than 15 centimeters, and assume a posture of mild generalized flexion and take shorter steps as if walking on a slippery surface or walking on ice. Wide base gaits are typical of cerebellar or sensory ataxia, and in some cases of mild ataxia, it may be evident only on turning and may disappear while walking in a straight line. But other than cerebellar or sensory ataxia, it can be seen in diffuse cerebral vascular disease and frontal lobe lesions as well. The eversion of feet is a strategy to increase stability and is particularly common in patients with diffuse cerebral vascular disease. So reactive, finally, Romberg's test followed by pull test. The pull test is sharply pulling the upper trunk backward or forward while the patient is standing. A few short shuffling steps backward is retropulsion, or the patient may have impending fall backward or forward. Backward steps are retropulsion and forward steps are propulsion. This suggests impairment in the writing reactions. Fall after postural changes such as rising up from a chair or turning while walking suggest impaired anticipatory postural responses. So this is the method of testing pull test as per UPDRS staging. The examiner stands behind the patient, informs the patient, and explains that patient is allowed to take a step backwards to avoid falling. There should be a solid wall behind the examiner at least 1 to 2 meters away to allow for observation of number of retropulsive steps. The first pull should be instructional and should be mild. The second pull should be brisk and forceful enough to displace the center of gravity so that patient must take a step backwards. If the patient recovers within 1 to 2 steps, it is normal. If the patient requires more than 3 steps, it is considered abnormal. That is slight postural instability. If the patient needs more than 5 steps, that is mild. If the patient stands safely but with the absence of postural response, falls, if not caught by examiner, is moderate, and severe is very unstable and tends to lose balance spontaneously or just with a gentle pull on the shoulders. I'll move forward to walking.
You can.
Yes, sir. So in walking, we assess initiation of stepping, speed of walking, stance base width, step walking, step length, cadence, rhythm, and tempo of stepping, step trajectory, which is shallow shuffling or high stepping, associated trunk and arm movements, and trunk posture. Sir, in initiation of gait, there might be a difficulty ranging from start hesitation to slipping clutch phenomenon to magnetic feet phenomenon. The start hesitation is the difficulty in which the patient needs a few short shallow shuffling steps to move forward. In slipping clutch phenomenon, the patient tends to move in one place and then move forward. And in the magnetic feet phenomenon, the patient's feet are seemingly glued to the floor. The patient may use exaggerated upper body movements to alter the step pattern, such as stepping sideways or lifting the feet very high in an effort to engage the legs in motion. In stepping, we should assess the length and trajectory of each step and the rhythm and tempo of stepping. Short, regular, shallow, or shuffling steps or shuffling and slow gait is characteristic of akinetic rigid syndromes. Shuffling is most evident when starting to walk, while stopping, or while turning corners. Freezing typically occurs during turning, when walking in confined spaces, and after encountering an obstacle with visual distraction, such as walking through a doorway, or if attention is diverted for any reason. Festination is increasingly rapid. Smaller steps is common in Parkinson's, but rare in other akinetic rigid syndromes. And it also helps differentiate frontal gait disorders from Parkinsonian gait disorders. The jerky steps of irregular or variable rhythm, length, and direction suggest ataxic or choric syndromes.
Yeah, go ahead.
Yes, sir. So we'll move on to types of freezing. That is start hesitation when gait is initiated, turning hesitation when destination hesitation when the freezing approaches a target, freezing when an obstacle is encountered, spontaneous sudden transient freezing, palilalia or freezing of speech. Apraxia of eyelid opening is also a form of freezing phenomenon, and there might be freezing of upper limbs. During turning, the slowing on turns may be the first abnormality in walking in a patient with Parkinson's disease. Multiple steps on turning are common in Parkinson's and diffuse cerebrovascular disease. An extra step or mild widening of the base on turning may herald the onset of ataxia. We should also perform more challenging tests of walking, such as walking on toes or heels. This might bring out minimal distal weakness, or it may bring out abnormal movements or dystonia, and can also reveal subtle weakness. We should also test for associated synergistic limb movements while walking, that is arm swing. A unilateral loss of associated synergistic arm swing while walking is a valuable sign of early Parkinson, but can be seen in unilateral cerebellar lesions and hemiparesis. The military marching gait or military two-step gait is observed in frontal lobe dysfunction or Parkinsonism. Involuntary movements are often superimposed on synergistic arm swing during walking, and dystonia or chorea may be more prominent on walking than on rest. Moving on to other maneuvers, that is tandem walking, walking backward, running, and walking on toes and heels. Tandem walking is abnormal in cerebral dysfunction, Parkinsonism. Walking backward improves dystonia in most dystonias except for DYT1 and tardive dystonias. Walking on toes and heels brings out abnormal movements or dystonia. And walking with dual tasking, this worsens the gait difficulty in elderly and patients with subcortical dementia. The patient is asked to hold some object in the upper limbs while walking, or the patient is asked to do a mental arithmetic calculation.
Okay, so this walking with dual tasking is also called as walking while talking test.
Yes, sir.
So you can ask so while the patient is asked to walk, you can initiate a conversation with him, or you can ask him to do some mental arithmetic. And the gait can worsen, or the patient can walk normally, and the abnormal gait can be unmasked.
Yes, sir.
Okay, go ahead.
So moving on to gait disorders. Gait disorders can be either due to peripheral dysfunction, that is due to joint disease, pain, muscle weakness, sensory loss, or due to lesions of the spinal cord and corticospinal tract, while central dysfunction is due to impaired postural control, impaired balance, and impaired stepping. Sir, peripheral gait disorders are waddling gait, that is due to weakness of the hip abductor muscles. In waddling gait, the non-weight bearing hip moves downward during the step, resulting in exaggerated alternation of the lateral trunk movement. This can be seen in LGMDs and other proximal myopathies. Steppage gait is seen in distal weakness, that is mostly the weakness of foot dorsiflexors. Quadriceps gait is seen in quadriceps weakness. At each step on the affected leg, the knee hyperextends and the trunk lurches forward. And this gait has a higher chance of falling while climbing stairs or getting downstairs due to buckling of knee. Antalgic gait is pain avoidance gait. It has a shortened stance, limp, and it is caused by arthritis, sciatica, or hip or knee joint pathology. Limb hypotonia or hemiparetic gait or circumduction gait. It is due to spasticity, which is characterized by leg extension and plantar flexion of the foot with leg circumduction and hip flexion in the swing phase. This is associated with an intermittent abduction of the ipsilateral arm with each step when it is unilateral, or or it presents with scissoring of the legs with bilateral circumduction when it is paraparesis, bilateral. There might be slight flexion of the hip and knee when standing, but on starting to walk, the affected leg stiffens and slightly extends at the knee. This typically extends when the patients are asked to walk faster because spasticity is velocity dependent. Other than spinal cord or UMN lesion, the causes can be stiff person syndrome, neuromyotonia, or myotonia. So moving on to central gait disorders. These are due to problems in gait initiation or due to problems in stepping. These are due to defective central control of locomotion. Problems in gait initiation are due to extrapyramidal gait syndromes and frontal lobe gait disorders. This may be in the form of start hesitation with shuffling on the spot, that is the slipping clutch phenomenon, or it can present as inability to lift the feet from off the floor, that is magnetic feet. Sir, I have prepared a short table on the central gait disorders. Hemiparetic gait, the localization is corticospinal tract. The cadence is slow. Stride length is short on the affected side. The step height is decreased due to the toe drag. There is asymmetry, and the limbs are spastic with difficulty in coordination and stiff movement. There can be hip hike, a circumduction, or foot inversion. In scissoring gait, the lesion is bilateral. The stiffness is also bilateral, and there might be adductor tightness as well. The step width is significantly narrowed. The legs are held narrow and the legs cross many times while walking. In Parkinsonian gait, there is the localization is basal ganglia and substantia nigra and striatum. The cadence is increased, that is rapid, short, shuffling steps, festination. The stride length is very short. Step width is decreased, and the step height is decreased. The symmetry, the arm swing can be reduced on one side, and asymmetry is found in early Parkinsonism, while on the late stages it can become bilaterally symmetric. There is bradykinesia and coordination, and other abnormalities are freezing of gait and difficulty in turning. While in frontal gait, that is due to normal pressure hydrocephalus or subcortical white matter disease, that is Binswanger disease, and frontal strokes. The cadence is decreased, stride length is decreased, step width is increased. It may be wide base and unsteady. To compare Parkinsonian gait with frontal gait, there is no freezing noted, although there can be magnetic gait, that is the feet are glued to the floor. In cerebellar ataxic gait, found in cerebellar stroke, MS, alcoholic cerebral degeneration, the gait is wide-based with the irregular stride length. The cadence may be normal or decreased. The step height is variable, and thus there is a high variability in symmetry and lateral sway. The coordination is severely impaired, and there is staggering, veering, and it worsens with tandem walking. Vestibular gait is due to central or peripheral vestibular lesions, that is vestibular neuritis, brainstem stroke, or Meniere's disease. The localization is vestibular nuclear, inner ear, or brainstem. The cadence is normal, stride length is normal. The step width is increased, and the falls are towards the affected side. It worsens in an environment which has moving objects. It worsens with head movement, and vertigo is usually present. In dystonic gait, there might be increased step height or hyperkinetic movements. There might be twisting movements and difficulty initiation gait. And usually there is abnormal posturing of the toe or the hand or the upper limb or lower limb. Asymmetry is very common. Apraxic gait, that is a type of frontal gait. There is severe asymmetry and there is difficulty sequencing movements and inconsistent step execution. The step width may be normal or increase and the stride length is decreased. There might be a severe asymmetry if the lesion is unilateral.
You're finished?
Yes, sir.
Yeah. Do you know about the levels of gait?
Levels of gait, as in, sir,
Yeah, there
yes, sir,
is
levels
something
of gait
called as
disorders. Sir, gait disorders can be classified as lower level gait disorders, middle level gait disorders, or upper
it
level
is
gait,
just a
higher level gait disorders.
yeah, it is just a revision actually of all this.
Yes, sir.
It is just a different type of classification. So
Yes,
lower level gait, basically it involves the distal or the end organs or the end part. So this
yes, sir.
includes the nerves and muscles.
Yes, sir.
So what are the lower level gait disorders?
Sir,
What will
due
you
to
see in lower level gait?
sir, lower level gait disorders can include waddling gait,
So
quadriceps
one is
gait.
myopathic. So in myopathic, what will you see?
Sir, we can see waddling gait, we can
Yes.
see high steppage gait, and
No,
quadriceps
no.
gait.
One is okay. Okay, distal you can get high steppage gait. Then waddling gait. Uh, those are because of abductor weakness. Then there can be exaggerated lumbar lordosis.
Yes,
So those are because of hip extensor weakness.
yes, sir.
Then there can be buckling while walking. That is because of quadriceps weakness.
Yes, sir.
Then neurogenic.
Sir, in neurogenic gait, there might be high steppage gait, and patient might drag the foot while walking, and there might be frequent falls due to
So high
tripping or
steppage gait. Yeah.
yes, sir.
Then sensory ataxia. So again, high steppage or slapping gait it is called as, or
Yes, sir.
stomping gait.
Stomping it, yes.
Yeah, and
Yes, sir.
vestibular, and fourth among that is vestibular. So there
Yes,
can
sir.
be veering gait. So the patient veers towards the side of the lesion while walking.
Yes, sir.
There is also a few tests which we can do to look for this. You aware about that?
Uh,
There is something called as star walking gait, star walking.
no, sir.
So the patient has to take 2 steps forward and 2 steps backward. And because of this veering, he will keep on moving sideways. So it will form like a star when he goes front and comes back.
Yes, sir.
That is what is called as star walking. There is something called as uh, Unterberger Fukuda test, which is also similar test. He has to stand on fixed markings and he has to he can take steps forward or backward or he can just lift his legs. That is performing high knees. And while doing that, there can be change in the because of veering, the axis can change. So
Yes, sir.
that can be seen in vestibular. What are middle order or middle order gait disorders or middle level gait disorders?
Sir, middle level gait disorders can be spastic gait, that is due to lesion at the level of spinal cord or corticospinal tract, cerebellar
Hmm.
ataxia, and
So because of corticospinal tract involvement first, so
yes,
spasticity. So there can be circumduction gait if there is unilateral involvement. If there is spastic paraplegia or diplegia, then
yes,
there can be scissoring. So scissoring gait because of strong adductors.
yes, sir.
Okay. Then second is cerebellum and its connections. So that
Yes,
is ataxia. So wide base gait, drunken man's gait, staggering or lurching gait, especially if they have involvement of flocculonodular node, then they have more of truncal ataxia. So
yes,
there, that is called as lurching or staggering gait while walking, or when they try to stand from sitting position, or when they try to sit up from supine position.
yes, sir.
Then there can be mixed of spasticity and ataxia. So that is spastic ataxic syndrome.
Yes, sir.
So that can be mixed. They can have spasticity also plus ataxia. Sometimes because of severe spasticity, they can have clonus. So It is mentioned as bouncing gait, that when they try to stand and walk because of the clonus, you can see them bouncing. That is called as bouncing gait. Then last is basal ganglia involvement, so hypokinetic or hyperkinetic. So in that hypokinetic can initially Parkinsonism can be the initial phase of Parkinson's can be middle order, but later as the Parkinson's advances, then it will become a higher order gait of involvement of frontal cortical circuitry also.
Yes, sir.
Uh, then hyperkinetic can be because of chorea, that is also called as dancing gait. Huntington's disease, they have mentioned lot of words, stumbling gait, lurching gait, and there is something called as marionette gait. So marionette is actually a puppet which has strings attached to all its limb, and the person manipulates the string while the puppet moves. So that is called as marionette gait. Then have you heard of rubber man gait?
Sir, is it seen in stiff person syndrome? I'm not very
In
sure, sir.
neuroacanthocytosis. So in
Yes.
neuroacanthocytosis, along with or it is called as choreoacanthocytosis also. So they
Yes.
have chorea and they have dystonia of the trunk. So because of chorea and truncal dystonia, especially the truncal dystonia is at the hip. So they move forward and backwards and sometimes sideways. So that's why it is called as rubberman's.
Yes, sir.
Then there can be dystonic gait also. So dystonia, so that is while walking. So there can be striatal toe. So that is when there is some dystonia in the lower limbs. It can be seen in Parkinsonism also. Then they can have excessive hip flexion while walking. That is seen in that rubberman's gait. Then have you heard of peacock-like gait?
No,
So
sir.
that is seen in some MBIs also. There is flexion of the hip. It is seen in generalized dystonia. There is
Yes, sir.
flexion of the hip, there is flexion of the knee, and plantar flexion of the foot. While walking, they can assume that posture. So that's why it is called as bird-like or peacock-like gait.
Yes, sir.
Then in manganese toxicity, there is something called as
Yes, sir.
cockwalker's gait or cockwalk gait. That is also similar.
Yes.
And what is higher order or higher level gait disorder?
Sir, higher level gait disorders are mostly due
So
to
here,
dysfunction.
basically, the frontal, cortical, and subcortical circuits are involved.
Yes, sir.
So it is also called as gait apraxia or lower order Parkin or lower limb Parkinson's.
Yes, sir.
So what are the causes?
Sir, normal pressure hydrocephalus,
Yes,
subcortical dementia, sir, and PIGD variant of Parkinsonism or PIGD variant of PSP can also cause uh,
yes,
level gait disorders, and vascular Parkinsonism can also present.
yes. And whatever you said, Binswanger's disease.
Yes, sir.
So uh, that can also cause then hydrocephalus, long-standing chronic hydrocephalus, frontal lobe disorders like frontal lobe tumors. Uh, then sometimes cerebral anoxia or HIE also, manganese toxicity. All this can cause and long-standing Parkinsonism. Uh, CJD can also cause. So all this can cause. So they are given few examples. There is one box differential diagnosis of akinetic rigid syndrome and gait disturbance.
Yes, sir.
So all this can cause. So what kind of gait do you get in this patient?
Sir, in higher level gait disorders, there is mainly, sir, decrease in gait velocity.
So yes, so we called as gait apraxia. So they have
Yes, sir.
difficulty while walking, but if you ask them to do any other bipedal activity
Yes, sir. Cycling,
while cycling,
pedaling. Yes,
yeah,
sir.
they will be able to do. So they can have freezing. Uh, they can have worsening while doing simultaneous tasks.
Yes,
Okay,
sir.
they can have gait hesitation and magnetic gait. So they will have very short shuffling gait. They will not lift the leg above the ground.
Yes,
Okay,
sir.
they can have freezing also. One thing to note is the arm swing can be normal or exaggerated also. The
Yes,
gait which you mentioned, that is military two-step gait. It
yes,
is
sir.
also called as marche petit gait, that they have exaggerated on normal arm swing, but they have short shuffling gait or magnetic gait.
Yes, sir.
Okay. Then what is cautious gait?
Sir, patient tend to walk with a wider base, with a shorter stride length, and the trunk slightly flexed forward, as if walking on a slippery surface or a ice surface. This is usually seen in elderly patients.
So, elderly and patients who have the perception of or fear of falling
Yes, sir.
due to fear of impaired balance, they can be seen in elderly. Yes, so they have short steps and they have the posture is slightly stooped, and that is to uh, change the center of gravity for better balance.
Yes, sir.
And what is hysterical gait? The frontal, this part of higher level gait.
Sir, the
Sorry,
historic,
this is not part of higher level gait, cautious gait and hysterical. So in hysterical gait, what can you get?
sir, non-patterned,
Yes, so non-patterned and
non-patterned.
fluctuating
Yes,
gait.
sir.
So they can have the semiology can differ. So they can have knee buckling without falls. They can have excessive slowness, abnormal step length or stride length, exaggerated body swing, or
Yes,
trembling of hands and feet. All this can be. And
yes,
last is antalgic gait, which you have mentioned.
yes, sir.
Okay, anything else, or you're finished?
Yes, sir. Uh, I finished, sir. These many slides I added, sir.
I think actually everything is covered. Does anyone want to ask anything?
Yeah,
Sir,
anybody
what
have
is
any
Rubberman's
questions?
gap?
Yeah.
Hello, sir.
Yes, Rubberman skate is in chorioacanthocytosis actually,
Sir, why it is called so, sir?
because there is sudden truncal flexion. So it is like the man is made up of rubber. So when he walks, so there is sudden flexion of the trunk forwards. Sometimes there can be trunk backwards and laterally also. So it is like the man is made up of rubber, and then that's why it is called as Rubberman skate.
Thank you, sir.
With star walking, you mentioned another test, sir. Could you please repeat that? Star walking and the other test.
It is Untenberger Fukuda. When you actually, it is not, you don't use that test for checking gait. Those are actually tests which are done to test vestibular functions.
Yes, sir.
So we don't generally use it to look for gait. But that I just mentioned, uh, what is wearing and how wearing affects those tests. So those tests are the positive because of the wearing. Like when you read the vestibular function in the journal, I think you can. There is one called as Untenberger Fukuda test and star
Yes.
walking, but we don't use it for gait.
Yes, sir. So there's one more question in the chat box, sir. Difference between falls and drop attacks.
So actually, fall is just inability to maintain upright during postural challenge. Now, drop attacks is sudden fall only, uh, but it is usually without any prodrome. It can be associated with loss of consciousness. Usually, it is associated with loss of consciousness, and secondly, there can be change in tone of the muscle, which leads to sudden fall. So, for
Yes.
example, the patients with cataplexy, uh, patients with TIA involving anterior cerebral circulation, then atonic seizures. Here, there is no loss of consciousness, but there is sudden loss of tone. That sudden loss of tone doesn't occur in the other falls which we see. That's why the falls are somewhat classified into toppling falls and collapsing falls also. So the toppling falls is an umbrella term which includes all the other kind of falls. For example, falls due to uh, neuromuscular disorders, falls due to hypokinetic or hyperkinetic disorders. While drop attacks are called as collapsing falls, where there is collapse of the person because of either loss of consciousness or because of loss of tone.
Yes, sir. Sir, one more question regarding pattern of injuries in falls and its significance.
This pattern of injuries, these injuries are, uh, see, initially in hypokinetic disorders, initially the patient will try to protect himself while falling. So initially there may not be any injuries. This mainly these injuries are seen in this you should ask in neuromuscular falls. So for example, falls because in muscular dystrophy because of buckling of the knee. So because of buckling of the knee, they usually fall on their knees. So they have multiple injury marks on the knees. In tripping falls, they can have injuries on the lateral side of the leg. They can have injuries on the foot or on the ankle also. In PSP, sometimes there can be injuries on the posterior side of the skull because of fall backwards.
Yes, sir.
Okay, if there are no more questions, we will conclude the session. Thank you, Dr. Ratnesh, and thank you, Dr. Noel, for moderating this
Yes,
session.
it
And
was overall good. I think most of the points were covered in the presentation itself.
yeah,
Thank you,
it
sir.
was very nice, detailed presentation. Uh, so from tomorrow, we'll focus on case presentation, and next week we will have some classes on interactive session on hyperkinetic diseases, and followed by case presentation. So we'll close this session. Thank you, everyone. We'll close. Thank you, everyone. Okay.
Thank you, sir.